Alrighty, guys, we have a screen. Welcome to one more podcast. Today we're talking about diabetes and action potentials, pressure volume cycles. Let's get into it. ChatGPT, are you here?
I'm here. Diabetes, action potentials, and pressure volume cycles. Sounds like a packed episode. Where do you want to start?
Amazing. Let's talk about diabetes mellitus. What is this mellitus?
Sure. Diabetes mellitus is a condition where the body has trouble regulating blood sugar. It happens due to issues with insulin, which is the hormone that helps cells absorb glucose. There are two main types. Type 1, where the body doesn't produce insulin, and type 2, where the body can't use it effectively.
Okay.
All right. What aspect of diabetes do you want to dive into first?
So the question. Sorry for the noise, guys. I touched my guitar. So let's talk about type 1. Why not?
No worries. Type 1 diabetes is an autoimmune condition. The immune system mistakenly attacks insulin-producing cells in the pancreas, leading to little or no insulin. This means glucose builds up in the blood, so people need insulin therapy to manage it.
So we have no insulin.
Exactly. Without insulin, cells can't absorb glucose for energy, which leads to high blood sugar levels. This requires careful monitoring and insulin injections to maintain balance.
Interesting. And let's talk a bit about the classic symptoms too.
Sure. Classic symptoms of type 1 diabetes include excessive thirst, frequent urination, unexplained weight loss, extreme hunger, and fatigue. These symptoms usually develop quickly.
Interesting. Okay. And explain to me this autoimmune destruction of the beta cells that you mentioned.
Sure. In type 1 diabetes, the immune system mistakenly targets and destroys the beta cells in the pancreas. These cells are responsible for producing insulin. The exact cause isn't fully understood, but it involves genetic and environmental factors. This autoimmune response...
And when do the beta cells come from?
Beta cells develop in the pancreas, specifically in clusters called the islets of Langerhans. They're essential for producing and releasing insulin, which helps regulate blood sugar levels.
Guys, I'm using the highlighter. Okay. And so it's autoimmune. And what are the islets of Langerhans and why are they named as such? And what do they have to do with diabetes?
The islets of Langerhans are tiny clusters of cells in the pancreas that include beta cells. They're named after Paul Langerhans, who discovered them in the 19th century.
And are these beta cells?
Yes, exactly. Beta cells are part of the islets, and they're responsible for producing insulin. When these cells are destroyed in type 1 diabetes, insulin production is impaired, leading to the symptoms. Right? So managing type 1 diabetes involves replacing that lost insulin.
Okay, that makes sense. So sometimes it follows viral infection like mumps, rubella, measles, and I wonder why.
That's a great question. Some researchers believe that viral infections can trigger the autoimmune response in genetically predisposed individuals. The virus might cause the immune system to mistakenly attack beta cells while fighting the infection. This is still an area of ongoing research.
Interesting.
It is fascinating. The interplay between genetics, the immune system, and environmental triggers is complex. It's why type 1 diabetes can sometimes seem to appear unexpectedly after a viral illness.
So I'm a bit confused. So beta cells are destroyed. What about alpha cells?
Alpha cells, which are also in the islets of Langerhans, aren't typically destroyed in type 1 diabetes. They produce glucagon, a hormone that raises blood sugar. The main issue in type 1 is the loss of beta cells, leading to insulin deficiency.
So explain to me one more time alpha cells and beta cells in the pancreas and how they're affected when it comes to diabetes type 1.
Sure. In the pancreas, alpha cells and beta cells have different roles. Alpha cells produce glucagon, which raises blood glucose levels. Beta cells make insulin, which lowers blood glucose. In type 1 diabetes, the immune system mistakenly attacks beta cells, reducing or eliminating insulin production. This causes high blood sugar levels.
Tell me more.
Certainly, when beta cells are destroyed in type 1 diabetes, the body can't produce insulin. Insulin is essential because it allows glucose to enter cells for energy. Without it, glucose builds up in the bloodstream, leading to high blood sugar. This can cause symptoms like excessive thirst, frequent urination, and fatigue. Managing type 1 diabetes involves monitoring blood sugar levels and taking insulin to regulate those levels.
So glucagon will remain high, basically. Is glucagon produced by alpha cells?
Yes, exactly. Alpha cells produce glucagon, and in type 1 diabetes, glucagon levels can be high because there's no insulin to counterbalance it.
And do beta cells break down glucagon usually?
Not exactly. Beta cells don't break down glucagon. Instead, they release insulin, which lowers blood glucose and counteracts glucagon's effects. Glucagon, produced by alpha cells, raises blood glucose by signaling the liver to release stored glucose.
One more time, Seb.
Sure, beta cells don't break down glucagon. They produce insulin, which lowers blood glucose. Glucagon, made by alpha cells, raises blood glucose by signaling the liver to release stored glucose.
Oh god, I'm confused. Tell me one more time, please. Sorry guys. Hey bro, tell me one more time what you just said. I don't understand. So alpha cells produce glucagon, but what do beta cells do?
Got it. Alpha cells produce glucagon, which raises blood sugar.
Beta cells produce insulin, basically.
Exactly. Beta cells produce insulin, which helps lower blood sugar levels.
Yeah, that makes sense. All right. Can we talk a bit about metabolic consequences of type 1 diabetes?
Sure, type 1 diabetes can lead to metabolic consequences like diabetic ketoacidosis, where lack of insulin causes the body to break down fat for energy, producing ketones. This can make blood acidic. Other issues include hyperglycemia and long-term complications like nerve damage or kidney problems.
Diabetic ketoacidosis.
Right. Diabetic ketoacidosis, or DKA, happens when there's not enough insulin. The body breaks down fat for fuel, producing ketones, which can acidify the blood. It's a medical emergency with symptoms like nausea, vomiting, and confusion, requiring immediate treatment.
And why does this happen?
DKA happens because the body can't use glucose without insulin. So it starts breaking down fat for energy, producing ketones as byproducts. The accumulation of ketones makes the blood acidic, which can lead to serious complications if not treated promptly.
Okay. Okay.
Exactly. Glad that helps. Anything else you'd like to dive into?
So, if we have insulin deficiency, do we have more or less protein breakdown?
With insulin deficiency, there's typically more protein breakdown. The body starts breaking down proteins for energy, along with fats, since it can't use glucose properly.
Tell me one more time.
Sure, with insulin deficiency, the body breaks down more proteins for energy because it can't effectively use glucose.
So it breaks down more protein. I don't understand why it breaks down more protein.
No worries. Without insulin, cells can't take in glucose for energy. So the body turns to alternative sources, like breaking down fats and proteins.
Okay, this makes sense. And do we have, what about glycogenolysis when we have insulin deficiency?
With insulin deficiency, glycogenolysis increases. This means the liver breaks down stored glycogen into glucose, further raising blood sugar levels.
Why does it increase?
It increases because, without insulin, the body thinks it's in a low energy state. So the liver releases more glucose from glycogen stores to compensate.
But we have a lot of already, basically. I see.
Exactly. And that excess glucose builds up in the blood, causing hyperglycemia.
That makes sense.
Glad it does. If you have more questions, I'm here.
Yeah, let's jump to another topic of the day. And I want to talk a bit about circulation first. So, if we talk a bit about circulation, cerebral circulation in general.
Sure. Cerebral circulation refers to the blood flow in the brain. It supplies oxygen and nutrients while removing waste. Maintaining consistent blood flow is crucial because the brain is highly sensitive to changes in oxygen levels. Disruptions can lead to issues like stroke.
Okay, can we talk about the circle of Willis?
Sure, the circle of Willis is a ring-like arterial structure at the base of the brain. It connects major arteries, ensuring consistent blood flow, even if one part is blocked.
Okay,
It's a key-
and what about the renal circulation?
Renal circulation focuses on blood flow to and from the kidneys. It's crucial for filtering blood, removing waste, and regulating blood pressure. Proper renal circulation is vital for kidney function and overall fluid balance.
Okay, that makes sense. And lastly, I want to just talk about skin circulation.
Sure, skin circulation helps regulate body temperature and supplies nutrients to the skin. Blood vessels near the skin surface can constrict or dilate to manage heat loss or retention. It's essential for protecting against temperature extremes.
All right, now let's talk about the pressure volume loop.
All right, pressure volume loops are used to understand the relationship between pressure and volume. They're especially useful for diagnosing heart conditions and assessing cardiac performance.
Explain to me, sir, why are they so good at doing this?
They'd be helped by illustrating the heart's efficiency in pumping blood, highlighting any issues with filling or ejection. The shape and position of the loop can reveal problems like heart failure or valve disorders.
Interesting. Okay. Can you give us an example?
Sure. For example, in heart failure, the pressure volume loop may show reduced stroke volume and increased ventricular pressures, indicating the heart's reduced ability to pump effectively.
Okay, let's talk about filling and ejection. Let's say you have a pressure time graph. How is this supposed to look? I mean, guys, is there a ruler in this machine? Give me a second, ChatGPT.
Sure, take your time. The pressure time
Can I
graph
put a box?
typically...
Sorry, sir. Sorry, tell me. Okay, guys, I'm gonna learn how to do this, but for now, bear with me, okay? Pressure and time.
No worries. On a pressure time graph, you'll see a rapid increase during ventricular contraction, systole, and a drop during relaxation, diastole.
Yeah, that makes sense. So we have ejection, and then the diastolic pressure. What's gonna happen in diastolic pressure? Is it gonna be this like horizontal?
Yes, during diastole, the pressure decreases and eventually levels out, appearing more horizontal.
Is it completely horizontal or with a small incline?
There's usually a slight incline incline due to ongoing ventricular filling.
Interesting. Okay, that makes sense. That makes sense. Let's continue this a bit then.
Sure, let's keep going. What's next?
What's the dicrotic notch?
The dicrotic notch is a small dip in the pressure waveform, seen during the closure of the aortic valve. It marks the end of systole and the start of diastole.
So, where would we see it in the pressure time graph?
You'd see the dicrotic notch as a small downward deflection right after the peak of systole, just before the pressure drops during diastole.
So the first ejection is diastole.
Actually, the first ejection is during systole. Diastole is the relaxation phase, when the ventricles fill with blood.
But wait, sir, ventricular contraction is systole, correct?
Yes, exactly. Ventricular contraction is systole, when the heart pumps blood out.
Ventricular contraction is systole. Yeah, that's right. Sorry. So this part here then on the right is gonna be diastole, and so the rise is gonna be systole, and the downward gradient is gonna be the negative gradient is gonna be diastole then.
Exactly. The upward slope represents systole, when the ventricles contract, and the downward slope represents diastole, when the ventricles relax and fill with blood.
That makes sense.
Great. Glad it's clear now.
Okay. So then let's go back to the dicrotic notch then. So the dicrotic notch is during the down. So if it's during down, this means getting blood out. It's a contraction, systole.
The dicrotic notch actually marks the transition from systole to diastole. It's the brief dip right after the aortic valve closes, signaling the end of systole.
What the heck? Wait. Yes, I got it the other way around. Systole, it means the opposite. Systole is the first step. Yeah. That makes sense. So, okay. So when systole finishes and diastole starts, then?
Exactly. The dicrotic notch indicates that moment, marking the end of systole and the beginning of diastole.
And we have 4 valves, and so basically we have atrioventricular and semilunar. So semilunar are the second valves and atrioventricular are the first ones, right?
Yes, that's right.
That's a good point. And so basically what you're saying is that the aortic valve, which is going to the aorta, which is the left semilunar valve, this one, yeah, that makes sense then, that is the aortic valve. Yeah. Okay, so aortic valve closes when there's no more to basically throw out. Yeah, that makes sense. So dicrotic notch then. Dicrotic notch, what is this?
Exactly. The dicrotic notch represents the brief drop in pressure after the aortic valve closes, signaling the end of systole and start of diastole.
One more time.
Yep, that's it. It's a key feature on pressure time graphs.
Wait, tell me one more time. So what's the etymology of it?
The term dicrotic comes from Greek, meaning double beating, because it reflects the double pulse sensation from the closure of the aortic valve.
One more time? One more time. Please. Sir, please tell me one more time. What is crotic?
Dicrotic means double beating, referring to the second, smaller pulse felt after the main heartbeat due to the aortic valve closing.
Okay.
Glad that helps.
Oh, I like writing, guys. This is fun. Okay, so it's also an extra way for me to express myself to you guys.
That's awesome.
All right, so can we talk about the valve sounds S1 and S2?
Sure, the valve sounds S1 and S2 are the lub-dub sounds. S1 is the closure of the atrioventricular valves, and S2 is the closure of the semilunar valves.
Sorry, guys, my friend Adam came and politely distracted me, which I'm grateful for. So let's continue. Yeah, we were talking about S1 and S2. So can we talk about S1 and S2 sounds, ChatGPT?
Sure, let's talk about S1 and S2 heart sounds. S1 is the lub sound caused by the closure of the mitral and tricuspid valves at the beginning of systole. S2 is the dub sound, produced by the closure of the aortic and pulmonary valves at the end of systole. These sounds give us clues about how the heart valves are functioning.
Okay. So lab is atrioventricular, dub is semilunar.
Exactly. S1, the lub, is the sound of the atrioventricular valves, the mitral and tricuspid, closing. S2, the dub, is from the semilunar valves, the aortic and pulmonary, closing.
Okay, that makes sense. So let me. Okay, let's talk about the ECG waves a bit too, since we're at the topic of hearts and action potentials.
Sure. An ECG shows the heart's electrical activity. The P wave represents atrial depolarization, which is the atria contracting. The QRS complex shows ventricular depolarization, or the ventricles contracting. And the T wave represents ventricular repolarization, when the ventricles relax.
Okay, so the P wave should be like in my pressure time graph. It should be completely in the beginning then.
Yes, exactly. The P wave corresponds to the beginning of atrial contraction, so it lines up early in the cardiac cycle on a pressure volume graph, right before the rise in atrial pressure.
And the QRS should be like basically during systole.
Exactly. The QRS complex coincides with ventricular systole, where the ventricles are contracting and pumping blood out to the body and lungs.
That makes sense. Okay, let's talk a bit about the pressure volume graph too.
Sure. The pressure volume graph, or loop, represents the cardiac cycle. It shows changes in the left ventricle's pressure and volume throughout one heartbeat. The loop starts with ventricular filling, followed by isovolumetric contraction, then ejection, and finally isovolumetric relaxation.
Okay, so I don't understand the shape. Why does it look the way it looks?
Great question. The loop's shape reflects different phases of the cardiac cycle. The bottom line shows ventricular filling, where volume increases but pressure stays low. The steep rise is isovolumetric contraction, where pressure rises but volume doesn't change. The top line is ejection, where both pressure and volume drop. The final descent is isovolumetric relaxation, where pressure falls but volume remains constant.
Okay, so kind of parallel to the x-axis will be in the bottom the feeling, because we have more volume and we don't have more pressure really, maybe a bit from the stretching or something, I don't know. And then we have the same amount of volume, but we have a lot of pressure. I assume that's during systole.
You're on the right track. That steep vertical line where volume stays the same but pressure rises is during isovolumetric contraction, which is part of systole. The ventricles contract, increasing pressure without changing volume until the aortic valve opens.
Mm-hmm.
And once the aortic valve opens, the ventricles eject blood, which reduces the volume, as you see in the top part of the loop.
And why does and pressure will increase during that? Wait a second. So if we feeling, and then pressure. Well, I'm a bit confused. So wait a sec. We have why in the feeling we have not much increase in pressure? I mean, I get why, but then suddenly we have this kind of vertical. Immediately we have this vertical pressure, and then why do? Okay, actually it makes sense. Sorry, I'm just being a bit silly.
No worries. It's a complex topic. The vertical rise in pressure happens because the ventricles are squeezing down on the blood, but the valves are still closed, so the volume can't change yet. It's all about the ventricles building pressure.
Does the aortic valve close again after ejection on the top left of the graph? Is it top left?
Exactly. After ejection, when the blood's pumped out, the aortic valve closes, which is at the top left of the graph. That's when the ventricles relax, pressure drops, and we move into isovolumetric relaxation.
And they go to the beach, and they sit down. Okay.
Haha, yep. The ventricles get to chill out for a moment before starting the cycle all over again.
Alright, now, how will this graph change if we have pathologies?
Good question. Pathologies can alter the shape. For example, in aortic stenosis, the pressure during ejection rises more sharply, making the top part tinier. In heart failure, the loop might be smaller due to reduced stroke volume.
Okay, for instance, in aortic stenosis, in aortic stenosis, I assume we will have more pressure. I'm gonna more pressure here, we have more vertical pressure on the right side, right?
Yes, exactly. In aortic stenosis, you'd see a taller pressure curve during ejection because the ventricle has to work harder to push blood through the narrowed valve. So, more pressure on the right side of the loop.
Okay, and then in mitral stenosis, what would happen in mitral stenosis?
In mitral stenosis, the filling phase would be affected. The ventricle has difficulty filling because of the narrowed mitral valve. So the loop might show a lower volume and less steep increase in pressure during filling.
Lower volume? Interesting. I'm confused about the differences between mitral and... okay, we're gonna do mitral as yellow. Just a sec. So, let's do it blue. So I'm confused about the difference between mitral and aortic stenosis.
Sure, the key difference is location. Mitral stenosis affects the valve between the left atrium and ventricle, impeding blood flow into the ventricle. Aortic stenosis involves the valve between the left ventricle and aorta, affecting blood ejection from the heart.
Well, if we sit down and think about it, it makes sense. We will have more pressure and we will have less volume. But why is the less volume in aortic stenosis shown like from 1 to 5, it goes 4 to 5, but with mitral stenosis from 1 to 5 is like going 0 to 3. Does that make sense what I'm saying?
I get what you're saying. In aortic stenosis, the volume reduction is mostly during ejection. while mitral stenosis affects filling. So the starting volume is lower in mitral stenosis. Both conditions make the heart work harder, but in different
Okay,
ways.
yes, exactly. You get what I'm saying. So why is it lower? Why is the starting volume lower?
In mitral stenosis, the narrowed valve restricts blood flow from the left atrium to the ventricle. So the ventricle starts with less blood, resulting in a lower initial volume on the graph.
Interesting,
filling-
interesting. And what about regurgitation then? And how would that look? And how would mitral and aortic regurgitation compare with each other?
Regurgitation means the valve doesn't close properly, allowing blood to flow backward. In mitral regurgitation, some blood flows back into the atrium during ventricular contraction, which can make the loop appear wider. Aortic
It's almost
regurgitation-
like an egg. Why does it look like an egg?
It does look a bit like an egg. The shape is due to the different phases of the cardiac cycle. With regurgitation, the loop widens since blood is moving in both directions, making it appear more rounded.
And with aortic?
In aortic regurgitation, the loop also widens, particularly at the bottom, because blood flows back into the ventricle after systole, increasing the volume during relaxation.
This is so interesting to me. I don't understand why it reaches higher pressures when it's aortic stenosis or regurgitation, and it also reaches higher volumes.
It can be a bit tricky. In aortic stenosis, the ventricle needs to generate higher pressure to push blood through the narrowed valve. In regurgitation, higher volumes occur because blood leaks back into the ventricle, increasing the end
Yeah, that
diastolic
makes
volume.
sense. That makes sense. Okay, we've talked about S1, we've talked about S2. How about we talk about how myocytes contract? What even? Yeah, let's talk about that.
Sounds good. Myocyte contraction starts with an action potential, causing calcium release inside the cell. Calcium binds to troponin, allowing actin and myosin filaments to slide past each other, shortening the muscle fiber and causing contraction.
So we have myosin and we have actin. And tell us about this myosin and actin and the sliding filament model and all of this.
Sure, in the sliding filament model, myosin heads bind to actin, forming cross bridges. These myosin heads then pull the actin filaments toward the center of the sarcomere, shortening the muscle. This process is powered by ATP, which provides the energy for the myosin heads to detach and reattach.
Tell me more about this.
Absolutely. When calcium binds to troponin, it causes a shape change, exposing binding sites on actin. Myosin heads attach to these sites, perform a power stroke, pulling actin, then release, recocking to repeat the cycle.
Oh wow, I'm so confused, dude. I'm so confused. And we have thin filaments and so thin filament is thin filament is actin. First of all, why are they called myosin and actin?
No worries, they're named after the proteins themselves. Myosin is the thicker filament with motor heads, and actin is the thinner filament. The names just reflect their structure and function in muscle contraction.
Let's pull out a picture here, guys.
Visual aids can definitely help. Seeing the filaments in action makes it easier to grasp.
Guys, I want to do this better and better, and I think I have to find a way to pull up pictures like immediately. I don't know how. Okay, so we have this actin and this myosin. Okay.
You'll get the hang of it.
And so, wait a sec. So myosin, what does it do?
Myosin acts as the motor. Its heads bind to actin, then pivot, pulling the actin filament. This sliding action shortens the muscle, causing contraction.
Alrighty, guys. So we left off ChatGPT. Sorry, I had a small break. We left off with myosin, actin, thick and thin filaments. Could you fill the gaps?
No worries. Sure, we were talking about muscle contraction. Myosin and actin are the key players. Myosin, the thick filament, has heads that bind to actin, the thin filament, and pull it, causing the muscle to contract. This interaction is powered by ATP. Anything specific you'd like to dive into?
Yeah, could you include troponin and tropomyosin and all that?
Absolutely. Troponin and tropomyosin are regulatory proteins on the actin filament. Tropomyosin blocks the myosin binding sites on actin when the muscle is relaxed. When calcium binds to troponin, it causes a shift that moves tropomyosin away, exposing the binding sites for myosin. This allows muscle contraction to occur. Pretty cool, right?
Yes, sirree.
Awesome. Anything else you'd like to cover about muscle contraction or related topics?
Yeah, so it still has for me to. So why is myosin the thick one and why is the thin one actin?
Great question. The main difference is in their structure. Myosin is a larger, thicker protein with a tail and head that can bind to actin and pull it. Actin, on the other hand, is a thinner filament made up of smaller globular units. Together, they create the sliding motion needed for muscle contraction.
Yeah, I asked why though.
Ah, got it. So myosin is thicker because it has a more complex structure, with multiple protein chains and heads that interact with actin. This design allows it to generate the force needed for contraction. Actin is thinner and simpler, forming a scaffold for myosin to pull on. It's all about their roles in the contraction process.
And how does myosin consume ATP?
So, myosin consumes ATP during muscle contraction by breaking it down in a process called ATP hydrolysis. The myosin head binds to ATP, which provides the energy for the myosin head to change shape, bind to actin, and perform the power stroke that pulls actin along. After the stroke, another ATP binds to release the myosin from actin, resetting the cycle.
Troponin and myosin bind together to form tropomyosin and then the actin filament is exposed?
Not exactly. Troponin and tropomyosin are separate proteins. Tropomyosin blocks the myosin binding sites on actin. When calcium binds to troponin, it causes a shape change that moves tropomyosin, uncovering the binding sites. This allows myosin to attach to actin and initiate contraction.
Tell me again.
Sure, troponin and tropomyosin are separate. Tropomyosin blocks myosin binding sites on actin. When calcium binds to troponin, it changes shape, moving tropomyosin away. This exposes the binding sites on actin.
So again, sorry guys, I don't know why it's taking me so long.
No worries. Troponin and tropomyosin are distinct proteins. Tropomyosin blocks myosin binding sites on actin. When calcium binds to troponin, it shifts tropomyosin.
Wait.
Those sites.
Can we break it to 3 steps?
Sure. Step 1. Calcium binds to troponin. Step 2. Troponin changes shape, moving tropomyosin. Step 3. Myosin binding sites on actin are exposed.
Why does calcium bind to troponin?
Calcium binds to troponin because it triggers muscle contraction. When a nerve signal stimulates muscle fibers, calcium is released inside the muscle cell. Troponin has a specific site for calcium, and when calcium binds, it changes troponin's shape, allowing it to move tropomyosin and expose the binding sites on actin.
So troponin moves tropomyosin?
Exactly. When troponin binds calcium, it shifts tropomyosin away from actin's binding sites. This allows myosin to attach and initiate muscle contraction.
Okay, and then?
Then, myosin binds to actin, performing a power stroke that slides actin, causing the muscle to contract. After that, ATP binds to myosin, releasing it from actin, and the cycle repeats.
Calcium binds to troponin. Then tropomyosin says, troponin moves tropomyosin, and then what is tropomyosin? Is it myosin with? No, it's not a myosin with troponin. So how does myosin and actin, are they in step 3 then?
Exactly. Tropomyosin isn't a combination of myosin and troponin. It's a separate protein that blocks actin's binding sites. In step 3, myosin heads bind to actin, forming cross bridges and generating the force from muscle contraction.
So actin is covered by what molecule?
Actin is covered by tropomyosin. It blocks the myosin binding sites until calcium binds to troponin, which
So
then moves
actin is
tropomyosin.
covered by tropomyosin.
Yes, exactly. Tropomyosin covers actin's binding sites until troponin, with calcium, shifts it away.
And troponin kicks it. And exposes
Exactly.
it. Does it expose it to myosin then?
Yes, it does. Once tropomyosin moves, myosin can bind to actin, starting muscle contraction.
Mm-hmm.
Glad that makes sense. Anything else on your mind about this process?
So myosin and troponin are two gangsters, and myosin gives money to troponin to move tropomyosin so it can go to actin.
That's a fun way to put it. Myosin and troponin definitely work together. Troponin handles the security with tropomyosin. And once calcium comes in...
So actin is in love with tropomyosin, and then basically troponin is the third wheel that will steal actin by myosin is the third wheel, but because it doesn't have good social skills, it tells to troponin to kind of help him out, make some lies about tropomyosin or something.
Love the analogy. Myosin definitely needs troponin's help to get past tropomyosin and bond with actin. It's like troponin's the ultimate wingman, making sure everything's set for the actin-myosin romance to happen.
Alright, let's continue talking about a bit about the ion channels and how they control voltage, please.
Sure, ion channels are proteins in cell membranes that allow ions to pass through. They open or close in response to changes in voltage, like a gate. This process is crucial for electrical signaling in cells, especially in neurons and muscle fibers.
Interesting.
Glad you find it interesting. Want to dive deeper into how specific ion channels work?
Yes, sir. Let's talk about K and NA. So, for instance, with K we have delayed rectifier and inward rectifier. Can you explain us this?
Absolutely. Potassium channels, like the delayed rectifier, open slowly during an action potential, helping repolarize the cell by letting K+ out. Inward rectifiers, on the other hand, allow K+ to move more easily into the cell, stabilizing the resting membrane potential.
Tell me more about this.
Sure. The delayed rectifier channels are crucial for repolarizing the membrane after depolarization, preventing excessive excitation. They open slowly and let K+ out, restoring the negative membrane potential. Inward rectifiers primarily allow K+ to enter the cell, helping maintain a stable resting potential by counteracting small changes in voltage.
Interesting.
I'm
Okay,
glad you think so.
what does rectifier mean?
Rectifier, in this context, refers to how these channels preferentially allow ion flow in one direction. Delayed rectifiers mainly let K+ out, while inward rectifiers favor K+ entering the cell, hence the names.
Why don't we call it outward?
Rectifier highlights the channel's ability to favor one direction over the other. Inward and delayed clarify the specific direction and timing for potassium flow.
Okay, that makes sense. Let's talk a bit more about delayed rectifier K+ channels. So they're open when the membrane depolarizes.
Sure, let's dive into delayed rectifier potassium channels. These channels open in response to membrane depolarization, which means when the inside of the cell becomes less negative. They help repolarize the membrane by allowing K+ ions to flow out of the cell, restoring the negative charge inside. This process is crucial for resetting the electrical state of the cell after an action potential.
Interesting. And the inward ones?
Inward rectifier potassium channels, or KER channels, primarily allow K+ ions to move into the cell. They're more active when the membrane potential is negative, helping stabilize the resting membrane potential.
So the delayed ones take K+ out?
Exactly. Delayed rectifiers let K+ out to repolarize the cell, while inward rectifiers bring K+ in, maintaining the resting membrane potential.
Interesting.
They are, aren't they? It's fascinating how different types of potassium channels contribute to the overall electrical activity of cells.
Mm-hmm.
Absolutely. The balance between different ion channels is key for proper cellular function. It's amazing how finely tuned these processes are.
Alright, let's continue and let's talk a bit about action potentials now. So inward rectifiers then want to make it more positive, so assume that's in the beginning with atrial contraction.
Exactly. During an action potential, atrial contraction begins with depolarization. Inward rectifier channels help set the stage by maintaining a negative resting membrane potential. Once depolarization happens, other channels take over to drive the action potential forward.
So is it the QR part that's the atrial contraction?
Not quite. The atrial contraction corresponds to the P wave on an ECG. The QRS complex reflects ventricular depolarization. The atria depolarize first, causing the P wave, followed by the ventricles.
Wait, is it the P wave that's atrial contraction then?
Exactly. You've got it. The P wave represents atrial depolarization, leading to atrial contraction.
And then, okay. So the inward rectifier, I wanted to ask. Is it for both atrial and ventricular contraction that it activates?
Inward rectifier channels play a role in both atrial and ventricular cells, but they're more involved in maintaining the resting membrane potential. During contraction, other channels, like voltage-gated sodium and calcium channels, drive the action potential.
Interesting.
Yeah, the interplay of all these channels is pretty complex but fascinating. They all contribute to the precise timing and coordination of heartbeats.
And how come we have this positive feedback when depolarization occurs?
Great question. The positive feedback during depolarization mainly involves voltage-gated sodium channels. When they open, Na+ ions rush in, causing further depolarization. This triggers even more sodium channels to open, amplifying the depolarization until the peak of the action potential.
Interesting. And now we have repolarization too.
Exactly. Repolarization happens when potassium channels open, allowing K+ to exit the cell, which restores the negative membrane potential. This brings the cell back to its resting state, ready for the next action potential.
Interesting.
Yeah, it's a beautifully coordinated process.
Dude, I'm in love with writing on the iPad, I can't lie. To be honest, I usually do get bored with things sometimes. And then we have the refractory period and the after hyperpolarization. So can you talk to us about the after hyperpolarization and the refractory period?
Sure. The after hyperpolarization is when the membrane potential temporarily becomes more negative than the resting potential, often due to prolonged K+ efflux. It helps reset the neuron. The refractory period is the time during which the neuron is less excitable, ensuring one-way propagation of the action potential and preventing immediate reactivation.
Tell me more. So first comes which one?
The refractory period has two phases. The absolute refractory period, when no new action potential can be generated, and the relative refractory period, when a stronger than normal stimulus is needed. After hyperpolarization typically overlaps with the relative refractory period.
Wait, what comes first? After hyperpolarization or refractory period?
The refractory period comes first. It starts right after depolarization. After hyperpolarization usually occurs during the later part of the relative refractory period.
Interesting. So what is the job of the after hyperpolarization?
The after hyperpolarization helps reset the neuron's membrane potential. It makes it less likely for the neuron to fire immediately again, ensuring proper spacing between action potentials. This contributes to the precise timing of neural signals.
Interesting. So during after hyperpolarization, we have K plus and Na plus activity. K plus increases, Na plus decreases. Can you explain?
Sure. During after hyperpolarization, potassium channels remain open longer, allowing more K plus to exit the cell, making the inside more negative. Meanwhile, Na plus activity is minimal since sodium channels are mostly closed. This combination hyperpolarizes the membrane.
Tell me again.
No problem. During after hyperpolarization, potassium channels stay open, letting more K plus out, which makes the inside of the cell more negative. Sodium channels are mostly closed, so Na plus entry is minimal. This results in a more negative membrane potential.
That makes sense. Okay, and how does the ventricular myocyte action potential differ? Is it different, or are we talking about the same thing?
Ventricular myocyte action potentials are a bit different. They have a longer plateau phase due to prolonged calcium influx, which helps sustain contraction. This plateau phase isn't seen in neurons, making the ventricular action potential unique. This ensures a coordinated, strong contraction for pumping blood.
Tell me more.
The plateau phase in ventricular myocytes is crucial. It results from a balance between calcium entering the cell and potassium leaving. This extended depolarization allows sustained contraction, ensuring efficient blood ejection from the heart. This feature differentiates it from the shorter neuron action potentials.
This is what I call confusion.
It can definitely be a lot to take in. Just remember that the longer plateau in ventricular cells is all about ensuring a strong, sustained contraction. It helps the heart pump blood efficiently.
That makes sense. So why do we call it plateau phase?
We call it the plateau phase because on an action potential graph, the membrane potential stays relatively stable or flat for an extended period. This plateau results from the balance between calcium influx and potassium efflux, keeping the cell depolarized longer.
Tell me again.
So, during this plateau, the cell stays depolarized, allowing for a prolonged contraction. This is crucial for the heart to effectively pump blood.
I'm confused. People will hear my notes. It's so silly. Tell me again, bro.
Sure, the plateau phase is when the membrane potential stays stable after the initial spike. This happens because calcium ions enter the cell while potassium ions leave, balancing each other out. This keeps the cell depolarized longer.
So calcium current goes in and K goes out?
Exactly. Calcium flows in while potassium flows out. This balance maintains the depolarized state, creating the plateau phase.
Okay, interesting. Why not the other way around? They are both plus. Why don't we...
Good question. It's about the specific channels and their timing. Calcium channels open to prolong depolarization, while potassium channels eventually open to repolarize. This coordinated action ensures the heart contracts effectively.
Interesting.
Yeah, the timing is everything in cardiac cells.
Okay, let's talk more about ventricular myocytes. So at the rest we have the inward rectifier K plus channels. And what do they do?
In ventricular myocytes, inward rectifier K plus channels help stabilize the resting membrane potential. They allow potassium ions to flow into the cell when it's more negative, preventing excessive depolarization.
But then they start flowing out.
Exactly. During depolarization, they switch roles. Once the membrane potential becomes positive, these channels help K plus flow out, assisting in repolarization and returning the cell to its resting state.
Interesting. So
It's an
we have a rapid depolarization, and so which channels and ions are because of this?
rapid depolarization in ventricular myocytes is mainly due to voltage-gated sodium channels. When they open, Na+ rushes in, causing the rapid spike in membrane potential.
And then we have a bit of a decrease. What causes that?
After the Na+ influx, sodium channels close quickly, and transient outward potassium channels open briefly. This causes a slight dip in the membrane potential, leading to the plateau phase.
And then, okay, interesting. And then what's going on with calcium at that point?
During the plateau phase, voltage-gated calcium channels open, allowing Ca2 to enter the cell. This influx balances the K plus efflux, maintaining the depolarized state and prolonging contraction.
I see. And what happens when it goes rapidly down?
That's repolarization. It happens when calcium channels close and more potassium channels open, allowing K plus to exit. This brings the membrane potential back down to its resting state.
Interesting.
It's a beautifully...
That makes sense. Yeah. Can we talk about action potentials in the SA node and the AV node?
Sure. SA node action potentials are unique, featuring a slow depolarization phase due to funny currents and calcium influx. The AV node also has slow conduction, crucial for delaying impulses, allowing ventricles time to fill.
And tell me more about this. So, what's going on with calcium here and the usual suspects Na and K, and what's the funny current, and is it funny? And also, what's this kind of graph that looks like a Mexican hat almost, or kinda, I don't know, not exactly.
So in the SA node, the funny current, IF, slowly depolarizes the membrane. It's called funny because it activates during hyperpolarization. Calcium influx drives the action potential, and K plus helps repolarize. The graph's shape reflects these phases, creating a Mexican hat look.
Can you explain the Mexican hat look again?
Sure. The Mexican hat shape on the SA node graph shows a gradual upward slope or slow depolarization, followed by a peak and a downward slope as the cell repolarizes. This reflects the unique slow, steady depolarization and repolarization in pacemaker cells.
Interesting.
Yeah, it's a unique pattern compared to other action potentials.
Okay.
Glad that makes sense.
Yes, sirree. So, can you explain us the automaticity of the sinoatrial node?
Absolutely. Automaticity in the sinoatrial SA node means it can spontaneously generate action potentials. This happens due to the funny current, IF, and slow calcium influx, which gradually bring the membrane potential to the threshold, triggering a heartbeat.
Interesting.
It's pretty cool how the heart's natural pacemaker works.
Um.
Anything else you'd like to know about it?
Yeah, I would like to ask about the pacemaker potential. Is it the same thing or is it different on the SA and the AV?
The pacemaker potential is similar in both the SA and AV nodes. It's the gradual depolarization that brings the membrane to the threshold. The SA node usually sets the pace, but the AV node can take over if needed, though at a slower rate.
Okay.
Yeah, they're both essential for maintaining the heart's rhythm.
Okay, and can I ask about this weird graph of the pacemaker potential? It's like a horse jumping.
Sure, the pacemaker potential graph looks like a gradual slope upward, then a peak, kind of like a horse jumping. It shows the slow depolarization, then a sharp spike when the action potential fires, followed by repolarization.
Interesting. Okay, let's talk about the IF current again. This funny current or whatever it's called.
Sure, the funny current, IF, is unique because it activates when the membrane potential is more negative, helping the cell slowly depolarize. This gradual depolarization brings the SA node to the threshold, initiating the heartbeat.
So how does it make the SA node spontaneously active?
The funny current gradually depolarizes the SA node's membrane. Once it reaches the threshold, calcium channels open, triggering an action potential. This automatic depolarization is why the SA node acts as the heart's natural pacemaker.
I don't get it.
No problem. The funny current causes a slow, steady rise in voltage. When it reaches a certain point, it triggers the SA node to fire, creating a heartbeat.
Okay, and then it increases upon hyperpolarization. So does it always do a negative or so first it's positive and then it becomes more negative through the IF?
Yes, exactly. The funny current activates when the cell is more negative, during hyperpolarization. It then causes a slow depolarization, making the membrane potential more positive until it reaches the threshold.
Okay.
Got it. Anything else you'd like to dive into?
Yeah. How does IF lead to a net inward current?
IF leads to a net inward current by allowing Na plus and K plus ions to flow in, but more Na plus enters. This depolarizes the cell, gradually bringing it to the threshold needed for an action potential.
So K goes out, Na goes in, but more Na goes in.
Exactly. That net influx of Na plus is what slowly depolarizes the cell.
So this is during depolarization?
Exactly.
Well,
It's the initial...
what separates the IF from other activities of sodium and potassium? So, and tell me all the stages of IF, because you've talked to us about making it more negative, more positive. Let's break it to the necessary steps. Maybe there's 1, 2, 3, 4, 5 steps. I don't mind.
Sure. IF funny current is unique because it activates during hyperpolarization. Here's a simplified breakdown. 1. When the cell is hyperpolarized...
What is
IF
hyperpolarized? Tell me everything we were going to say. Tell me what is hyperpolarization.
Hyperpolarization is when the cell's membrane potential becomes more negative than the resting level. This often happens after an action potential, making the inside of the cell more negatively charged. That's when IF kicks in, starting the next depolarization cycle.
Interesting.
Yeah, it's a crucial part of the pacemaker process.
Okay, can we talk about so hyperpolarization makes things more positive inside?
Hyperpolarization makes the inside more negative. Then, the funny current, IF, gradually makes it more positive, leading to depolarization.
Okay. And what does ivabradine do to it?
Ivabradine specifically inhibits the funny current, IF, reducing the heart rate by slowing the SA node's depolarization. It's used to manage certain heart conditions.
Okay, let's talk about blocking ion channels of cardiac action potentials now.
Sure, blocking specific ion channels can alter cardiac action potentials. For instance, blocking sodium channels slows depolarization, while blocking potassium channels prolongs repolarization. Calcium channel blockers affect the plateau phase, reducing contractility.
Can you give us more examples?
Of course. For example, lidocaine blocks sodium channels used as an antiarrhythmic. Amiodarone blocks potassium channels, prolonging repolarization. Verapamil, a calcium channel blocker, reduces heart contractility and slows conduction.
All right, let's go back to diabetes, which we started talking about. So let's talk about the diabetic state in the liver. Yeah. Can we mention also like acetyl-CoA and how that plays a role in ketone bodies?
Sure. In diabetes, the liver increases gluconeogenesis, producing more glucose. Acetyl-CoA accumulates from fatty acid breakdown, leading to ketone body production. This can cause ketoacidosis, especially in type 1 diabetes.
And so, what about acetyl-CoA?
Acetyl-CoA is a key molecule in metabolism. When it accumulates, it drives ketone body production in the liver. This happens when there's insufficient insulin, like in diabetes, leading to increased fatty acid breakdown.
I think this noise that I do with the pen is gonna annoy the shit out of you guys. I'll have to find something. Okay, let's talk about the ketone bodies then. So if we have prolonged low insulin, eventually we have ketone bodies that become ketone bodies from fatty acids that become acetyl-CoA.
Exactly. When insulin is low, fatty acids break down into acetyl-CoA, which then forms ketone bodies. These ketones can be used as an alternative energy source, but excessive production leads to ketoacidosis.
Amazing.
It is fascinating how the body adapts, but it can be dangerous in diabetes.
Yes, sirree, yes, sirree, yes, sirree, yes, sirree.
Exactly. Managing insulin levels is crucial.
And can we talk a bit about the formation of ketone bodies?
Sure. Ketone bodies form when acetyl-CoA accumulates. This happens in the liver through ketogenesis, creating molecules like acetoacetate, beta-hydroxybutyrate, and acetone. They're then released into the blood for energy use.
Alright guys, another small break from me, but let's continue ChatGPT with the formation of ketone bodies that we were talking about. Explain to me how acetoacetate and delta beta hydroxybutyrate are involved in this situation with acetyl-CoA and TCA cycle.
Sure, let's break it down. During periods of low glucose, like fasting, your liver converts fatty acids into ketone bodies. This process starts with acetyl-CoA. When acetyl-CoA accumulates, it gets converted into acetoacetate. Then some of that acetoacetate is reduced to beta-hydroxybutyrate. These ketone bodies can then travel to tissues like the brain and muscles, where they're converted back to acetyl-CoA for energy production in the TCA cycle.
I didn't understand the part with acetoacetate and delta beta hydroxybutyrate. How did this come into play? And the TCA?
No problem. Let's simplify. When there's not enough glucose, your liver breaks down fats, creating acetyl-CoA. Excess acetyl-CoA is turned into ketone bodies, like acetoacetate and beta-hydroxybutyrate. These ketones are energy sources. They travel to tissues, are converted back to acetyl-CoA, and then enter the TCA cycle for energy.
Why do they go back to acetyl-CoA?
They convert back to acetyl-CoA because that's the molecule that enters the TCA cycle for energy production.
Well,
tissues like
why
the
do they
brain,
even become ketones at the first place?
ketones form because during fasting or low glucose states, the liver breaks down fats for energy. Acetyl-CoA from fatty acids accumulates, and since it can't all enter the TCA cycle, it's converted into ketones. This allows other tissues to use them as an alternative energy source.
This is confusing to me. So from acetyl-CoA they become ketones, and from ketones they become acetyl-CoA, and then they go to the TCA cycle.
Yes, that's correct. Acetyl-CoA accumulates and forms ketones in the liver. These ketones travel through the blood to tissues like the brain, where they're converted back to acetyl-CoA. There,
Well, what's the
acetyl-CoA
functional reasons of them becoming ketones in the first place?
Ketones serve as an alternative energy source when glucose is scarce. The liver converts fats to ketones because many tissues, especially the brain,
And
can't use
what, when they're done, they become back to acetyl-CoA?
Exactly. Once ketones reach tissues like the brain, they're converted back to acetyl-CoA. This allows them to enter the TCA cycle, providing energy where it's needed.
Interesting. Okay, let me ask you a question then. So they go back to acetyl-CoA. I understand that, but okay. Actually, let's keep it there.
Sounds good. If you have more questions, just let me know.
Explain to me how this kind of insulin lack contributes to hyperglycemia.
Sure. When insulin is lacking, glucose can't enter cells efficiently. This causes glucose to build up in the bloodstream, leading to hyperglycemia. Without insulin, the liver also continues to produce glucose, adding to the high blood sugar.
Tell me a bit more, dude.
Absolutely. Insulin's main job is to help cells absorb glucose from the blood. When there's not enough insulin, cells can't take in glucose, so it stays in the bloodstream. Plus, the liver keeps making and releasing glucose because it doesn't get the signal from insulin to stop. This combination results in high blood sugar levels, or hyperglycemia.
Interesting. Okay, let's talk a bit about adipose tissue and how the uptake of glucose is diminished by the loss of insulin, and how the glucagon ratio enhances lipolysis, and we have this breakdown of tricyl glycerol, etc., etc. Enlighten us more.
Sure. In adipose tissue, insulin promotes glucose uptake and inhibits lipolysis, the breakdown of fats. When insulin is low, glucose uptake decreases, and glucagon steps in to enhance lipolysis. This causes triglycerides to break down into free fatty acids and glycerol, providing energy and substrates for gluconeogenesis, further raising blood glucose levels.
Interesting. Okay. Let's talk a bit about how ketoacidosis can become life-threatening, and let's talk about the long-term problems of diabetes, such as retinopathy, nephropathy, neuropathy, organ damage.
Absolutely. Diabetic ketoacidosis, DKA, can be life-threatening due to severe dehydration, electrolyte imbalances, and acidosis, which can lead to coma or death if untreated. Long-term complications of diabetes include retinopathy, which can cause blindness, nephropathy, leading to kidney failure, and neuropathy, resulting in nerve damage. These complications arise from prolonged high blood sugar, damaging blood vessels and organs.
Interesting. That makes sense. Can we talk a bit about glucose in excess and why it's toxic? Perhaps if we could mention the osmotic damage and the reactive oxygen species and glycosylation, advanced glycation end products.
Sure, excess glucose is toxic because it causes several harmful effects. High glucose levels lead to osmotic damage, pulling water into tissues and causing swelling. It also promotes the formation of reactive oxygen species, which damage cells. Additionally, glucose binds to proteins, forming advanced glycation end products, which contribute to inflammation and further tissue damage.
Interesting. Let's talk a bit about how we diagnose diabetes, and then let's jump to HbA1c.
Sure, diabetes is usually diagnosed through blood tests like fasting plasma glucose, oral glucose tolerance test, or HbA1c, which measures average blood glucose over the past 2 to 3 months. An HbA1c of 6.5% or higher indicates diabetes.
Can you further explain this a bit?
Of course, the fasting plasma glucose test measures blood sugar after an overnight fast. Levels of 126 milligrams per deciliter or higher suggest diabetes. The oral glucose tolerance test involves drinking a sugary solution, then measuring blood sugar 2 hours later. Levels of 200 milligrams per deciliter or higher indicate diabetes. HbA1c reflects the average blood sugar over a few months by measuring the percentage of hemoglobin with glucose attached.
Interesting.
It's fascinating how these tests give us a clear picture of blood sugar control.
Okay. So what does HbA1c stand for?
HbA1c stands for glycated hemoglobin. It represents hemoglobin with glucose attached, reflecting average blood sugar levels over the past 2 to 3 months.
One more time. Sorry guys, I was unprofessional. I just paid my rent. Okay, tell me again, brother.
HbA1c, or glycated hemoglobin, measures the percentage of hemoglobin with glucose attached. It reflects your average blood sugar levels over the last 2 to 3 months.
Okay, that makes sense. Can we talk now a bit about treatment?
Sure. Treatment from diabetes includes lifestyle changes, like diet and exercise, along with medications. For type 1 diabetes, insulin therapy is essential. For type 2, options range from oral medications to insulin, depending on severity. Monitoring blood sugar is key for managing the condition.
Interesting. Okay, and we basically mimic normal daily insulin secretion through treating.
Exactly. In type 1 diabetes, insulin therapy mimics normal insulin secretion, balancing blood sugar throughout the day. This often involves a combination of long-acting insulin for baseline levels.
Can you explain us the difference between long-acting, fast-acting, intermediate-acting?
Sure. Long-acting insulin provides a steady baseline level over about 24 hours. Intermediate-acting insulin works for around 12 hours.
And when do we get which? Huh? So when do we get which? Sir?
Fast-acting is taken at mealtimes to handle blood sugar spikes, and intermediate-acting is often used twice daily. The specific regimen depends on individual needs.
Interesting. And we have NPH. What's NPH? We have Lispro, and we have Detemir. What are these names?
These names refer to different insulin types. Lispro is a fast-acting insulin, while Detemir is long-acting. Each has specific uses based on how quickly they work and how long they last.
Interesting. Okay. Okay, let's talk a bit about diabetes mellitus. Remind me what mellitus means. And this time let's talk about type 2, and let's talk about insulin resistance and B cell dysfunction. So once more, maybe ChatGPT didn't listen to us. Please talk to me about mellitus. What does it mean? Then type 2, and let's talk about beta cell dysfunction and insulin resistance, please.
Got it. Mellitus means sweet, referring to the excess sugar in urine. In type 2 diabetes, insulin resistance means the body cells don't respond well to insulin, so glucose isn't absorbed properly. Beta cell dysfunction means the pancreas doesn't produce enough insulin to compensate. Both issues lead to high blood sugar.
Okay, what's insulin resistance though?
Insulin resistance happens when cells don't respond well to insulin, making it harder for glucose to enter them. This forces the pancreas to produce more insulin. Over time, it can't keep up, leading to elevated blood sugar levels.
Okay, can we talk about the causes of type 2 diabetes now? Let's talk a bit about the insensitivity of target cells, if you could explain that to us, and the impaired insulin secretion in general. Excuse me.
Sure. The body becomes resistant to insulin. Normally, insulin helps cells take up glucose from the blood. But with insulin resistance, those cells don't respond well. The pancreas compensates by producing more insulin, but eventually it can't keep up. This is combined with impaired insulin secretion, where the beta cells in the pancreas don't release enough insulin. This combo leads to high blood sugar levels.
So, what are these target cells and why are they so insensitive?
The main target cells for insulin are muscle, fat, and liver cells. They're crucial for regulating glucose. Insulin resistance can develop due to excess fatty acids, chronic inflammation, or genetic factors. Over time, these cells don't respond properly to insulin, which means they can't absorb glucose efficiently. This leaves more glucose in the blood, leading to higher blood sugar levels.
Interesting. Can we talk about insulin resistance a bit more and how it combines with adipokines from adipose tissue and excess fatty acids, defects in cellular translocation of GLUT4, and if you could explain that a bit?
Absolutely. Insulin resistance is linked to adipokines, which are signaling proteins released by fat tissue. In obesity, these adipokines can promote inflammation and disrupt insulin signaling. Excess fatty acids also play a role. They can accumulate in tissues like muscle and liver, impairing their response to insulin. This results in defects in the cellular translocation of GLUT4, a glucose transporter. Normally, insulin triggers GLUT4 to move to the cell surface, allowing glucose entry. In insulin resistance, this process is disrupted, contributing to high blood sugar levels.
Interesting.
Yeah, it's pretty fascinating how all these factors interconnect.
Okay, let's talk a bit more about the GLUT4 thing.
Sure, GLUT4 is crucial for glucose uptake. In response to insulin, GLUT4 moves from inside the cell to the cell membrane, acting like a gate for glucose to enter. In insulin resistance, this translocation is impaired. So even if insulin is present, glucose can't efficiently enter the cells.
Can you remind us GLUTs 1 to 5 or whatever, what do they do, where is the location?
Sure. GLUT1 is found in most cells and is responsible for basal glucose uptake. GLUT2 is in the liver, pancreas, and kidney, handling glucose transport in and out of cells. GLUT3 is primarily in neurons, with high glucose affinity. GLUT4, as we discussed, is in muscle and fat cells. GLUT5 mainly transports fructose, not glucose, and is found in the small intestine.
So, who put these numbers? Is it like based on when they were discovered or what?
The numbering of GLUT transporters isn't strictly chronological. It's more about discovery order and distinct functional differences. Scientists named them GLUT1, GLUT2, etc., as they identified and characterized each transporter's unique role and location. So it's a mix of timing and function.
Interesting.
Yeah, it is. The GLUT family plays such a vital role in how our bodies manage glucose.
Okay, let's talk a bit about the metabolism in type 2 diabetes and how it differs from type 1.
Sure, in type 2 diabetes, the main issue is insulin resistance and impaired insulin secretion. The body still produces insulin, but it's not used effectively, leading to high blood sugar. In type 1 diabetes, it's an autoimmune condition where the immune system attacks insulin-producing beta cells in the pancreas, leading to little or no insulin production. So, type 1 requires insulin therapy, while type 2 might be managed with lifestyle changes, oral meds, or sometimes insulin.
What about the glucagon level raise? Is it the same?
In type 1 diabetes, glucagon levels tend to be higher because there's no insulin to suppress it. This can worsen hyperglycemia. In type 2, glucagon is also often elevated, but it's due to insulin resistance and impaired beta cell function. So, while both types see elevated glucagon, the causes differ.
Okay, how do oral hypoglycemic agents help with type 2?
Oral hypoglycemic agents help manage type 2 diabetes in various ways. Some, like metformin, reduce glucose production in the liver and improve insulin sensitivity. Others, like sulfonylureas, stimulate the pancreas to release more insulin. There are also meds that slow carbohydrate absorption or increase insulin's effect. Combined, these approaches help lower blood sugar levels.
What about sulfonylureas? What the fuck is this? Sorry guys, but Jesus.
No worries. Sulfonylureas are a class of oral medications for type 2 diabetes. They work by stimulating the pancreas to release more insulin, which helps lower blood sugar. Common ones include glipizide and glyburide. They're often used when lifestyle changes and metformin alone aren't enough to control blood sugar.
I was also going to ask about biguanides and thiazolidinediones. The worst thing ever, dude, is learning drug names.
I get it. Drug names can be a mouthful. Biguanides like metformin decrease liver glucose production and improve insulin sensitivity. Thiazolidinediones like pioglitazone enhance insulin sensitivity by acting on fat cells. They each help lower blood sugar in different ways, which is why they're useful for type 2 diabetes.
Perfect. Alright, guys, I'm going to wrap this episode up. Thank you so much for listening. Also, there's noise. Excuse me for the noise. It's not from me. It's from the people upstairs. I hope you enjoyed this podcast, and I'll see you next time.